Thank you very much, Professor 𝗏𝗏. It's a great pleasure and honor to participate in this fantastic event. I was asked by Dr. Ahmed Nassif to prepare a very big topic, so I will try to squeeze it in 10 minutes if I can. Our topic is about case selection for intervention for deep venous obstruction. I have no relevant disclosures. When we're talking about treating deep venous obstruction, it seems very simple. Just to achieve the best outcome, choose the right patient, choose the right lesion, and do the right procedure, you'll get a successful outcome. However, when we look how diverse the chronic venous disease manifestations that we face every day in our clinics and practice, you'd find that you have multitude of manifestations. So how can I identify which one have an obstructive component in these patients? So identifying the right patient is not that easy. Our diagnostic workup doesn't differ from yours. We start by clinical assessment, history examination, and then we image by duplex, and in some cases we order advanced imaging with CT venography and MRV. However, it's not what you do, it's how you do it that would predict the success. Our stepwise approach usually comes in 4 phases. We start by examining the patient and taking very good history, and then to answer one question, is it a venous complaint? That's the first thing. And if it's a venous complaint, we pass to the next phase where we do duplex ultrasonography and analyze the duplex findings with the clinical data, and then decide if the patient has manifestations that suggest the presence of obstruction or not. If so, we proceed to the next level with advanced imaging with CTV, using CTV, MRV, and then we interpret the results of these cases to find the answer, is it reconstructible? And if it's reconstructible, we then proceed to the planning, to the pre-planning of the procedure, and then we assess our outcome if it was successful. So if you go this way, you would find the answer, who is the right patient, what is the right lesion, and what is the right procedure, as we'll discuss in a few minutes. So first of all, with clinical assessment, we assess the lower extremity and we use the 𝗔 classification, the new one. However, you don't have to neglect the pelvis as part of the venous drainage. The SVP classification, I would recommend that you start using it. It was out in 2021, which includes the pelvis with the lower extremity, and it's very important in clinical assessment. And that's because, as we all know, the superficial drains into the deep through the junctions and perforators, and the deep then passes to the outflow in the pelvis. However, it's very important to know that there are external connections between the pelvis and the superficial veins, and you have to be very alert with these patterns that you see in your practice, that they are markers there. Although the patient is presenting with varicose veins in the lower extremity, however, it has pelvic origins. So in these cases, it's better to get a good look into the deep veins. Also, there are internal connections between the pelvic reservoir and the renal reservoir. So it's the lower extremity, pelvic, and renal reservoir, and these things you have to have a good idea about them in your back mind while examining the patient to fulfill a full examination of the patient. So always remember to assess the lower extremity and the pelvic and the pelvis as well for symptoms and signs. About the imaging, we use duplex ultrasonography. Of course, it's the perfect way to assess for reflux. However, for obstruction, duplex has its own limitations. In order to get meaningful assessment for the outflow, it needs special machine, special operator, and special patient, because in obese patients it's very difficult to assess for obstruction and needs a special examination protocol. So the best way to assess the deep veins is usually using CTV or MRV, or some patients just take the patient to the cath lab with venography and IVUS. But again, who should be investigated with these modalities? Should we investigate all patients with varicose veins for these modalities? Of course not. So over the past years, we have been able to collect some criteria that actually points which patient deserves to be further imaged with advanced imaging. Patients with venous claudication, this is an obstructive symptom. Patients who have been associated pelvic pains and pelvic manifestations is worth looking into the deep veins. Also, patients, as we mentioned, with extrapelvic varicose veins due to pelvic origin, anterior abdominal wall collaterals, vulval varicosities also need investigation. Also, patients with unilateral marked increase in the girth of the thigh more than 2 centimeters actually denotes that there is persistent venous hypertension, which is usually due to obstruction rather than reflux. And patients, after you do reflux ablation, who come with either early recurrence or worsening manifestations within 1 year, is worth looking in the deep veins as cause of recurrence. So these are the clinical criteria. And all patients, of course, with post-thrombotic syndrome deserve looking into the deep veins before you decide whether you would remove the great saphenous or ablate it, because sometimes it's the only drainage for a popliteal lesion, for example, so it's worth looking at the deep veins. So what about the duplex criteria? As described, lost common femoral vein, respiratory physicity, asymmetric waveforms, deep venous reflux in all popliteal and femoral vein segments, presence of pelvic collaterals. Sometimes you can see a popliteal venous aneurysm, and we published a correlation between the presence of popliteal venous aneurysm and iliac vein compression. And sometimes you can see the iliac vein compression with direct visualization, but as we said, it needs a very experienced operator to be able to see it. And of course, any post-thrombotic patient deserves to be investigated for the deep veins. So what about the notion that non-thrombotic deep venous obstruction, some nivels exist in asymptomatic population? Of course they do exist, yeah. And it's not recommended that we stent those patients at all. So the idea is that the solution for this dilemma is that simply do not treat asymptomatic patients just for having an iliac vein compression. And I would not recommend even investigating them by advanced imaging to find an iliac vein compression that has no symptoms. If the patient has no symptoms, there is no need for investigation firsthand. So what about doing the right procedure? Venous stenting, there are two strategies. You either pre-plan with CT venography, make all your pre-planning before going into the angio suite, and that's my preferred method. And while other centers rely on take the patient to the angio suite and then do IVUS and then decide what to do, I always prefer to pre-plan. I always prefer to never go blind. I take all my measurements with the CT venography, direct CT venography, of course, do all the hard work before going into the cath lab. As Professor 𝗘𝗴𝗆 illustrated brilliantly, that the most practical way of assessing the inflow is homogenized classification. This is very important. Inflow is very, very important and very crucial for success. So in the first three types, as Dr. Omar illustrated, the first three types give you very good results. However, when we're talking about type 4 or type 5 is not recommended at all for doing a procedure, for doing stenting. Don't waste your time. These patients have very poor prognosis if all the inflow is occluded. So for the type 4B, you have, for type 4A or type 4B, you need to extend your stent into the inflow vessel to secure the inflow. So inflow is very important. It's always nice to pre-plan, also to pre-plan the access site, because sometimes if you go into the fibrotic synechiae without a pre-planned access, you may find yourself lost and you cannot pass the lesion and go into collaterals, and that's because the intraluminal synechiae would direct you in the direction, in the false direction. So it's always good to pre-plan using CT venography. Never rely on venography itself, because venography has very high fallacy rate. You can miss a lot of obstruction because of the parallax that actually, when the vein is severely compressed, it might appear broader on venography. So never rely on venography. You can rely on IVUS, CTV, MRV, but not conventional venography. We always pre-dilate and post-dilate our lesions with high-pressure balloons, Atlas balloon. And there are lots of venous stents nowadays. All of them actually work. They differ in the method of deployment, but all of them do work. And I would quote O'Sullivan, I love them big and fatty. Don't use an undersized stent. Never, never, never use an undersized stent. Always oversize and use long stents, not short ones that can migrate easily. Always stent from healthy to healthy segment to get good outcome, and this needs pre-planning. And I do give liberal anticoagulation, especially in post-thrombotic cases that would extend anticoagulation maybe for life. In non-thrombotic cases, it's not even sometimes needed. However, no stent if the patient is asymptomatic. Definitely do not stent an asymptomatic patient. If you don't have a clear obstructive indication and no clear outcome to be achieved in terms of patient symptoms, do not do stenting. If you have poor inflow, never stent. If the sky is not clear during the procedure, if you see some ascending lumbar, it's vague, you don't know where you are, do not stent. It's better not to stent the patient rather than stent and If you don't have the right size stent, please do not put an undersized stent, never. So these are no stents. So in conclusion, Mr. Chairman, ladies and gentlemen, in non-thrombotic deep venous obstruction, don't forget to assess the pelvis as part of the venous drainage. Use advanced imaging only for symptomatic patients with obstructive manifestations, and stent only symptomatic patients to have excellent results of stenting. And in post-thrombotic deep venous obstruction, use advanced deep venous imaging in all symptomatic cases that you are planning to intervene who needs the intervention. Pre-planning is best rather than going inside and then you think what you do. And plan your access wisely, ensure good inflow, and stent from healthy to healthy. 𝗙VIS can help you post-stenting to assess your outcome. Give liberal anticoagulation for long periods in post-thrombotic cases. And that concludes. It's simple, easy. Choose the right patient, choose the right lesion, and do the right procedure. And thank you very much.